My name is Enderson Miranda. I'm the host for today's episode with Brian Floyd, President and Chief Operating Officer at ECU Health and Chairman of the Board for the North Carolina Healthcare Association. Brian brings over 3 decades of healthcare leadership experience and a unique perspective on the structural challenges that our rural healthcare systems have been facing for quite some time. I've had the pleasure of personally working very closely with Brian's team at ECU Health over the last several years, and I'm very excited to have this dialogue today with Brian, and where he's going to be really unpacking a powerful framework that redefines how we understand and see the challenges of rural healthcare systems today. So, Brian, welcome to the show. And the first thing that we typically like to do and ask our guests to do is you can share a bit about their journey, and so what has led them to where they are today. And so if you can share a little bit about your journey and specifically what makes you so passionate about rural healthcare, welcome.
Thank you. Thanks for having me. My journey began really, I grew up in a home with mom being a nurse and dad being a minister in a very rural environment, and at times on a mission front. And what that means is I came to appreciate perhaps earlier and shaped a bit by the idea that we need to create these constructs that just simply help people right there where they live and help support folks who particularly have challenges in their health condition. I watched that over the years, whether it was just, Sunday afternoon blood pressure checks and glucose checks and people just calling the house asking what they should do. So maybe it started way back then and I didn't realize it until I became older. But I started out my career as a nurse. I worked in an organization in cardiac surgery for years and ended up becoming a practice administrator of the heart and vascular surgery programs, leading to some roles as an executive to build a heart institute. And it was my first project, I suppose, with a hospital organization. And that involved a research institute and a freestanding heart hospital. Those things went very well, and they just kept asking me to do more things. And about every time I would think maybe it's time for me to do something different or a different environment, there would always be a pressing need. And what I have always loved about ECU Health in particular is it is situated entirely rural, entirely in a vast region of need. And so anything we do and do well has disproportionate impact. And so when there was always a new opportunity to take on a new thing, I was willing to do that and held a variety of roles then, from eventually the CEO of the Academic Medical Center, then ultimately now Chief Operating Officer of the health system. Our health system has 8 hospitals, one very large 1,100-bed tertiary center, and then some community hospitals, and about 200 and 250 clinics spread around eastern North Carolina. We have vast partnerships educationally, medical school, several nursing school partnerships, and allied health professional partnerships with colleges around us. And I have found fascinating that work over the years of how all of that shapes the missional alignment that we have over time as you learn and grow, and you're asked to help support statewide initiatives and things. It's gotten me into other roles like the Healthcare Association and others.
That's very impressive, Brian. And when you look into your background, right, from clinical to operations to senior leadership, policymaking, right, you really have the full spectrum to be able to see where, blind sides can exist sometimes, right, and where people may overlook or misunderstand some challenges that really specifically rural healthcare systems face. Can you share a little bit more, like when you look into this broader conversation around healthcare, what are those, right? So some areas that are misunderstood or perhaps overlooked.
Well, I will say I'm often asked why do I spend so much time at the state level or national levels with organizations that deal with policy, and it is because we all have to remember healthcare is local ultimately. The institutions that deliver it are usually very much a part of the framework and fabric of that local environment. But all of healthcare, no matter how big a health system is, no matter how small it is operating in a context that was created by policy, whether that is governmental policies that fund Medicare, Medicaid, whether that are policies at the state level that regulate what we can and can't do. Policies create the context for any healthcare system to be able to deliver its mission to improve, the health and well-being of its people. And I've become convinced that, particularly in this country, we are at a state where we have two healthcare environments in play that are vastly different from each other. One is an urban-based view, and the other one is a rural-based view. Those two are vastly different in many respects, but operating under the construct or the context of policies made at the federal and state level that assume that they're very much the same. When we talk about waste in a healthcare system, let's say, that you hear at the federal level, that doesn't mean that that's the same thing that's happening in some of these smaller rural environments where they're underfunded, perhaps. So I spend a lot of time on this issue because I believe we as healthcare leaders have an obligation not just to make sure the day operates well, but we're looking after the future of our organization's fulfillment of its mission. And that does require that we go upstream and talk about what context is there and how is it informed and how might it be changed to help make sure we can actually do this work that we're talking about. But those two issues of rural urban, neither is better. They're just different. And I'm not judging that one's wrong for the other one to struggle. It is simply the fact that the policies typically don't take into account the unique challenges that might exist in rural. And that's why we have a challenge today and why I'm so passionate about really fighting for rural needs in healthcare.
And I love how you've mentioned, several times as well in your different, advocacy for it, that, in addition to the differences that you mentioned, rural healthcare can be, structurally disadvantaged, right? Through a lot of the some of the challenges, and hence you created this framework, right? The 6 dimensions of rurality to kind of help us to understand those disadvantages, those challenges. Can you help walk us through what those 6 Ds are and why each one of those dimensions matter when we think about overall care delivery and organizational sustainability for those rural communities?
Well, absolutely. I'll start by saying, this is a construct that I have been using to help illustrate exactly what you said, illustrate what the challenges of rural. It's interesting. In the country now, we're hearing all about rural. There's the Rural Transformation Fund. There are rural challenges that are being brought up, which are great. And we're glad to see that there is a recognition of a crisis in our nation where a significant portion of our nation lives in these rural communities. Here in North Carolina, by the way, it's the second most rural populated state in the country. And a third of the people in this state are living in rural communities. So we have an obligation to really come to understand how do we present the challenge in a way that it's compelling towards solutions, not just by stating the problem. Example of that is when I speak to people about, who are talking about the rural issue, I first ask them, what is rural? What have you defined as rural? And I'll tell you that there are a lot of different answers, and there's ambiguity in the very statement of what you determine to be rural. And surprisingly, most people think they know that it's not a major metropolis kind of thing, but it can mean very different things. So I have tried to break what it is on the basis of what is the unique situation that creates a disproportionate challenge in fulfilling healthcare, instead of saying rural is just geographic. And the 6 dimensions I talk about are just 6 ways of describing those challenges that are unique to rural. And they look like this. One is density. The population density in rural markets looks very different than the population density, obviously, in urban environments. But what that can mean in a healthcare environment is patients are spread apart from each other, and there are no dense locations to set access in motion to those patients. And so when you're trying to reach 1 million people spread over 15 counties evenly in a geographic environment that's rural, where do you go and how do you reach them without having to put 15 different places that cost the overhead of 15 environments, right? So density is a real challenge, and density also leads to the lack of infrastructure being put in place in those environments. Because there's not enough density, commercialized businesses or pharmacies or other things also aren't present there. If you put a physician practice in a low density environment, will there be enough patient visits to actually make that break even? All those issues create a real barrier to the bricks and mortar hub and spokes models that we'd like to see happen in healthcare, because density plays a role. The second dimension is distance. And what I'm talking about are the structural challenges that are created by distances between patients, distances between them and healthcare resource, distance between them and food resources. When you're in a rural context, we talk about the challenge of food deserts or things of that nature. But imagine if where someone lives, the closest place of food is a gas station, then they're eating food that comes out of an environment high with sodium and other things that are not healthy for them because that's the closest place they can get. And some of them don't have a car. And so now you have a guarantee that you have a nutrition problem in a chronic disease patient because the distance to get to other resources is just simply too far. And then distances as a healthcare provider trying to reach them can be hours by country roads to get to the places where you've set up shops to try to help. Those distances play a role for sure. Demographic is the next one. That is more than the diversity, perhaps, but just consider the fact that in rural markets, you have the highest grouping of patients over the age of 65. The percentage of the population that fall into the category of our highest utilization group are in the rural market. So if I look at the population I serve, a greater proportion of them fall in the older category needing higher intensity resources. Yet they're in this rural context with its challenges. It also means you have less workforce potential, you have less resources applied around them. So urbanization is usually a youth issue. Young people urbanize, older people stay, and they're staying at a greater proportion of the population and therefore need more healthcare resource. The next one is disease burden. So there's a higher disease burden percentage. We all know a higher incidence of chronic diseases in rural versus urban as a percentage of it. And that's an important indicator on top of these other structural barriers that you'd have to take into account. It's not unique to rural that there is disease burden. In some cases, not unique, perhaps, that there's a percentage of a population with disease burden. What's unique is the other structural anomalies worsen that disease burden, make it more intense with less ability to help manage it in a rural context. The fifth dimension is the determinants. And by that, I'm referring to the social determinants of health. In rural versus urban, those social determinants, whether they're education gaps or whether they are wealth gaps, the context of the environment itself and the resources of the environment that are so vastly different, those social determinants and social vulnerabilities are higher in rural versus urban. And so that plays a massive role when you're thinking about trying to improve health outcomes in rural. The sixth dimension that we pay attention to is disparity. And by disparity, I'm not just talking about the healthcare disparity in outcomes, whether you divide them by race, gender, or whatever. I'm also talking about the disparity in the economic model that supports healthcare. Many people don't realize that you could take the same disease burden patient in a rural environment and the system caring for them will get paid less because they're rural, because of things like the wage index adjustment and factors that actually determine how much someone is paid for care. So we actually pay rural health systems less with all these other structural anomalies that make the job harder to do to get the outcome we're trying to get. At the same time, we are competing in America for outcome. And that's what's causing that big divide between rural and urban. And these six dimensions just help us see more clearly, not just geography is the answer to what rural is, but these real structural anomalies that have to be overcome that might lead to new policy of how we deal with the rural issues.
With all of the different changes and enhancements that we're seeing now for technology and AI and the fast growth that's impacting our industry, how do you see that and the impact that you will have specifically to rural healthcare and some of the challenges you mentioned earlier?
I think there's no question that this technology revolution we have is one of the enablers to help overcome some of these structural challenges that we've talked about, including how many people we have in the workforce and what kind of people we have to do the work. Fact of the matter is, people are afraid of AI many times when I talk about when in the context of careers, and yet I see that differently. The reality is, yes, there'll be change to jobs and the roles that people need to do today, but it frees up so much time for us to be really better at the thing that only a human can do, and that is love and care for the patient. Because we all know in healthcare, a lot of what we're delivering is love and care, not just medical science. And so imagine if we could take the 40% burden away from people spending time inside the computer and rather have the system help us be smarter about how to help the patient and spend our time with the patient. And so we've got so much hassle to remove in healthcare for healthcare providers. I don't worry about this AI thing. It's simply going to remove a lot of that hassle, and then we'll love the work even more because we're spending it in ways that feel right to us as humans. The other thing is the distance issue and the density issues. Those two things, trying to overcome them with bricks and mortar resources is part of the challenge, and it's impossible, which means the access gap remains. On the other hand, with teleconnectivity, that can be applied in almost any environment. The real question is, how do we build our health systems to be omnipresent when the ability to be in the home or ability to be in a place where patients have aggregated themselves is no longer the barrier? So I think us changing our own mindset and model about what does it mean to take care of that patient, we have to be imaginative that the technology will create an opportunity that we've never had before to be there when we're not there and be there across multiple low-density environments in a single day. The one clinic hub where all the exam rooms are in counties apart from each other, and we've learned how to reach the patients in that way. It's a fascinating time, and it's an exciting time, and yes, this technology is going to bridge a lot of these barriers for the future.
I couldn't agree more, Brian. And to your point earlier, right? Even though some people may be hesitant, and are concerned about utilization of AI, we within AMN are also on the mindset that this is really not going to substitute anyone's job. It's just going to really empower and allow us to do more with less, which it's been a challenge, right, within the healthcare system for quite some time. So I'm excited to see as well, to your point, the impact on that specific to the rural communities. Now, looking into all of those different dimensions together, where do you see those challenges showing up more clearly? Is it more, for the patient? Is it more on the caregiver side, or is it more on the healthcare system itself, or is it like an equal combination of them?
Well, they're very different answers depending on which angle you come at. From patients, the biggest thing they experience is an access gap. There's just no question that there's not the same accessibility of healthcare resources if you're in a rural context. And so that is the biggest thing, because remember, that doesn't prevent their disease manifestation. It doesn't necessarily de-escalate its escalation. For them, it's a matter of when I'm even really sick and I'm having the exacerbation of a disease, what do I do when there's no access close to me? What it usually means is I wait until it is critical enough that I have to be transported to an emergency department. And therefore, you see these very high utilization statistics of emergency departments in rural markets where there are fewer of them, further apart from each other, and overwhelming themselves trying to deal with the edges of disease management, not really disease management. So I think for patients, knowing that when you talk about, I like to talk about it this way. People talk about hospital closures in rural, and there's all these projected hospital closures, right? What's really important to note in that, the hospital closure is the tail end of closure, not the beginning of closure when it comes to healthcare resources. Before that hospital closed, you're already losing the infrastructure to support that hospital. That's why it ends up closing usually. So you have doctor loss, you have specialty care loss, you have obstetrics leave, you have specialized care models start to leave. And eventually, the first thing a health system would do to lower losses of expense in a rural market is not close the hospital. You scale back expensive unreimbursable services, which are the preventative services, and physician practice loss in those markets, knowing that you have this obligation for emergency care and that acute care. That's the tail end of it. So by the time you're closing hospitals, you've already lost a lot of other healthcare infrastructure to support chronic disease management. So patients in rural markets certainly experience the gap of access. For health systems, there's just a significant economic reality that we feel is more profound than anything else. And it's the reason then we struggle to create that access.
Yeah, no, that's really, really helpful, Brian, just kind of looking at the both ends of the spectrum, right? And understanding, and we're going to talk about here shortly, like some of the creative ways, right, that you're operationally, that you're able to overcome these challenges. But from a long-term sustainable perspective, right, policy making and being able to actually help those healthcare systems to be able to operate within an environment, that is more conducive. It's going to be really key. Now, from the policymaker hat, right, so like where do you see, and you touched on that earlier a little bit, but some of the biggest gaps between how policy is designed, and then how rural healthcare actually operates?
The biggest policy issue is payment reform. There just won't be healthcare resource applied where there's not an economic sustainability. The reality is our governmental agency is the obligated group of care for the public interest. And so health systems will contract or grow based on sustainability many times. And so their presence in solving the problem is dependent ultimately on resources they have to expense in that. Now, my health system, one of the reasons I love my health system is we are very mission driven. We do economically, we may be doing well in our academic medical center, but we are underwriting a lot of care delivery in rural markets that actually causes our margins to be greatly suppressed and distressed many times because we've placed ourselves where there's not sustainability. So that economic issue of policy is key. And what I'm hoping we do is influence with things like the 6 dimensions, making it clear on how might policy be shaped, not on the basis of just geography or on the basis which payer it is, whether it's Medicare, Medicaid, or whatever, but within those constructs, how do you deal with the structural issues by rewarding them with payments to help provide the resources necessary to overcome those barriers? And but I think that's the most important policy making issue that comes to my mind.
Yeah, definitely. And so looking into, from your policy making work and advocacy and your work as well within the chair, being the chair of the North Carolina Healthcare Association board. So in addition to healthcare, reimbursement reform, is there any other change that you see could be helpful to, to help offset some of those challenges?
There's a lot of answers to that question, and that's a very deep question because remember, the benefit of being in the healthcare association is I am with a group of people in healthcare systems all over our state who all have an equal love and responsibility to fulfill their missions. And what's different is not that. What's different is the context in which it is happening, and that creates different resources depending on which one of those you're in. And so I wouldn't want to suggest one's better, one's worse, or one policy that advantages one hurts another, or any of those kind of things. And there are tremendous federal pressures right now in policy reform and healthcare that we all are watching play out. From a policy perspective, we have to make sure that hospitals have the and health systems have the resources, policies that create competitiveness in that space, some view as good, but in a constrained environment, maybe there's some policy revision that doesn't allow necessarily there to be direct competition on outcomes as if there's an equal possible playing field there. And ultimately, I think it all just comes down to what we reward in healthcare and policy through payment reforms. And that's really where our focus is.
No, that's really powerful. That equitability mindset, right? That we need to definitely ensure that that's achieved. And to that, point, I'd love to shift a little bit into one of the biggest challenges financially as well is around workforce, and definitely a huge line item financially, operationally, and at ECU Health, you've been able to really overcome so many of those obstacles and really build the workforce in a way that has been impressive to see. So specifically to talking, on building that sustainable workforce, I know that ECU, you've played a very unique and intentional approach to workforce strategy that recruits from your local rural communities and just kind of builds them from within. And how have you learned about that, and how is that impacting retention and your long-term impact as well?
Well, for us, one thing to note is, I mentioned earlier we have lots of college partnerships, whether community colleges, universities. We are obviously part of a university health system. And I'd use nursing as a canary in the coal mine. There could be so many other disciplines of healthcare for which the same principle applies. But I started noticing something that is, as there is competition for slots in universities and colleges for certain training programs, you start to notice something about that is yet another structural anomaly of rural healthcare. And that is that in tier 3 or economically vibrant metropolis environments, urban environments, or just tier 3 economies themselves, obviously there are more educational resources in those markets. And there are homes with people who have more resources to apply to their educational environment and achieve a higher scholastic outcome, let's say. That doesn't mean, by the way, that if you compared a tier 1, maybe rural, economically suppressed home to a tier 3, that those humans in those homes aren't going to be equally passionate and equally capable. What it means is this one has perhaps more of an advantage in the educational systems to perform well scholastically on the testing programs and that sort of thing. What that looks like, though, is that eventually I noticed, even in our university, which is entirely rural-based environment, that ECU, a very large university sitting in a town of 70,000 people in a rural context, but the student populations would often be from outside of that rural context. And I would wonder why. Why would we have 70% of the students coming from outside of the rural context region we're in? And it has to do with competitive slots and competitive scholastic entry and things of that nature. And so we go, well, then the first thing we need to recognize is if someone is coming from an urban context outside of this market, training in our market, what is the likelihood they won't go back home or where they won't go back to an urban context when they're young? You're swimming upstream with workforce building if actually that's what's happening. And so, as part of our framework, we started asking these questions to learn and just try to discover if our missional aspect, not to say that we don't want to support the whole nation's workforce endeavors, and certainly at the state level, and we are an open institution, but if we have a workforce endeavor and a missional need to support Eastern North Carolina, then that might begin with also making sure that the people from those markets can train in these excellent programs and then be able to fulfill their life purpose and dreams within those markets, right? So we started looking at point system to say, how do we account for the fact that is there really an outcome differential from a 3.9 GPA and a 3.7 GPA? And if they're going to perform the same ultimately anyway, and we all know it's way below 3.7, that there's actually equal likelihood of credentialing success and performance and all of that, then how do we let geography connected to mission actually matter to the entry decision? And we've put some point systems in there to drive that where you come from and your missional alignment to the institution itself is part of your privilege of entry. And so it leads to perhaps a 10% or so shift of more students from our market being in those slots. I'm actually zooming in on that as simply a way of highlighting, again, the structural issues that can happen that make it more and more challenging to deliver these services in rural markets because even the workforce issues are affected by tier 3 versus tier 1 economic environments. And so we started just looking at that and saying, we're going to take responsibility to make sure all the educational programs around us, those especially that are fostering, people from within these tier 1 and Eastern North Carolina, in this case, rural markets, get opportunities into those educational programs. How do we participate in making that happen? And how do we provide some awareness and leadership to make sure those programs are able to succeed and the readiness needs of those folks? And I'm making the bet, of course, that the more we do that, the more we invest there, the more retention we will have down the road to pay for the investments. And so if I can make that differential up and then provide more scholarshiping to people from Eastern North Carolina, then what I'm really doing is fueling the mission of the organization to improve the health and well-being of the community, not just by taking care of them when they're sick. We're creating economic vitality, educational connections for them, which obviously raises their quality of life tremendously long before they are a patient. And so it's really that view that the way that ECU Health is going to fulfill its mission is, of course, clinical care in the market, but it is also education in the market and training and culture in the market. And then finally, the economic stimulus that our activity means to the market. Those three things are how we're actually proving the health and well-being of our market. And so we value them all. We are active in them all. We're working across, just this morning, I spent time with the president of one of the universities in our market, purely talking about how do we make sure we are advantaging the ability for rural people to enter these programs and get maximum benefit of that so that they will take care of their loved ones close to home. It's a big part of, I think, our strategy is people development.
Yes, that is so powerful, Brian. And to your point, right? You're directly impacting your organizational mission, and really, changing, not only the ability for you to get the qualified, caregivers and clinicians there, but also the likelihood that they will stay and grow and create a deeper and deeper draw within the community. And I also love to see that in addition to kind of drawing the local talent, growing and investing in your local talent, ECU Health has really leaned on to international clinicians as well. It's been very impressive to see that ECU, as you're bringing in, you mentioned nurses. So, for example, international nurses, that over 90% of them, or historically, that we have placed it over the years, convert into permanent ECU Health employees. And then their families are coming in as well, becoming part of that community and growing. That is, substantially higher than the conversion rates that we see nationally in other places. And I do believe that that sense of belonging, the culture and the community that you and your team created, ECU Health, there are really big portions for that. So I'd love to hear your thoughts as well on that. Some of those strategies, right? The local yet global, right? You're really bringing in both of them and in strengthening the well-being for the community as well.
Well, first thing I say is we're awesome. It's an awesome place, and people want to be part of awesome. I don't care where they live around the world. And I'm kidding a bit, but the reality is we are living out our mission. And I tell everyone that chooses to consider to be part of ECU Health, whether they're physicians, surgeons, or administrator, whoever, I always ask them the question, why do you want to be anywhere? Is it about the science of medicine? Is it about the economic issue? Is it about consequence of the organization? And if it's about consequence, meaning that I want to make sure I'm part of something that matters, then put a healthcare system like ours in the greatest population need and tell me how much that's going to matter. And so we try to attract people whose focus in their career aspiration has an awful lot to do with saying, I want to be where I know this hard work is going to make the most difference. Now, I would say every health system is making a huge difference. And every time we save a life in any health system, it's an amazing difference we make. There's no question. But because of all the other things we've been talking about, I just happen to know that ECU Health is a little bit unique in that it is so profoundly part of the fabric of an entire large region, economically and otherwise, that the work we do here, on top of the fact that it is such a profoundly need environment with very high disease incidence rates and burdens and economic issues and all, what that simply means is people are drawn to the missional aspect of knowing that you become part of the fabric of a community. Within any of our hospitals and clinics, they are the largest employer in every place that those hospitals are around this region. And they are very much the framework of the local community vitality. And the people that work there become leaders of the community. They also serve on the PTAs. They also use what they've learned and their knowledge and their insights and their energy changes the fabric of that community. And so people who are mission-minded love that, and they know that that is a consequential thing that lives on when you clock out. It's still going on. It's still part of your contribution. So we attract people who that's true for. Within our nursing in particular, as you mentioned with international nurses, I'm just proud of our leadership teams in our nursing departments that have really created a context for nursing. We are not a perfect organization. We are a learning organization. We are learning how to be more perfect. But we take very seriously the fact that people joining us is a privilege we have and an essential part of fulfilling our purpose and mission. And so when a person says, I want to be part of that, we simply are candid about we're going to do our best to get better and make sure that you love this place and that you feel connected to our mission. And, there are people from other nations that join here. And when you talk to them about, well, what made you stay here? It was never the economic things. It was never, the city itself, that kind of thing. It is, yeah, people often love this environment, but the reality is they talk about that mission and they talk about feeling so deeply connected to something that's making a profound difference.
Absolutely. And I can't tell you how many of our partners within, other organizations in the country come to us and ask us to introduce them and link them with your team at ECU Health so they can kind of learn and replicate, right, those best practices and really, help it, across the board. And, the last thing as we kind of approach, the end of the episode, just kind of wanted to kind of, look at broadly, right? Because you've said, often that you can't change your system by operating within your system alone, right? That leaders really need to be able to look outside and think about their roles in advocacy, their roles in partnering policy. So for those healthcare leaders watching today, what advice would you give them for really way to make sustainable change?
Well, the first thing is to don't underestimate your role in creating the knowledge that shapes policy. Advocacy matters, and it is more than showing up at a fundraiser somewhere and, supporting a given candidate. It is deeply about learning what are these structural issues and recognizing that our policymakers and the people that shape the rules and context for us know only what they know. And they're usually informed in environments that may not fully represent what these issues are. And so I tell people it's really important we engage. It's hard to do that. We are so busy. We have so much responsibilities to the daily work of making sure something as precious as healthcare is to the public is going as well as it possibly can. But we've got to carve out the ability to help educate our communities, educate the organizations within our communities, and then engage in the political processes in such a fashion that we are helping shape solutions. It is not enough for healthcare people to just talk about loss or talk about economic distress or simply state the fact that we don't have enough money or we're worried about closing this or that. It needs to be in the context of having built relationships with policymakers that allow you to say, and here's some things we can do about that. What I'm finding is the more we approach it that way, the more listening ears I hear in Congress and in local state politics, where we have folks that also took those jobs to try to help their communities. They understand healthcare is a vibrant part of the fabric of community success. So it doesn't benefit lawmakers to have it fall apart or have us just simply be unsuccessful. But we've got to bridge the engagement necessary to not just come for a cash transaction, come with solution to those barrier issues, having fully understood them. And then all of us working together to create a voice of reason around these issues is really important. And there are lots of organizations to engage in for healthcare leaders, but get involved in the process and align yourself with organizations that are trying to do that.
No, thank you, Brian. And so for the leaders that want to partner with you, learn more about your initiatives that you're supporting, where can they go to learn more and to be more involved?
Well, there's a lot of places to go to learn more. I would say, obviously, anyone can reach out to us at ECU Health. We are very transparent, easy to find, and all of our contacts are right out there. And we'd love to help any leaders that want to learn more and get involved in a process like this. We spend time talking to other institutions because we learn. And we learn that what I'm certain of in all the years I've been doing this for over 30 years, I'm certain that we don't know what we don't know. And I'm certain that other people have learned something we haven't yet. And that we don't need to judge the motive of a problem we have. It usually is an understanding gap. What we need to do is awaken that clarity for folks. So we want to help do that. And the more of us that do that together, the better. So they can reach us at ecuhealth.org. Find us all in there. I'm Brian Floyd. Email's right out there. We'll be happy to help any way we can.
Thank you, Brian, for sharing your expertise and your leadership today. Your insights have really helped us to see and reinforce, what is needed in strengthening rural healthcare, which is really that having that the true understanding of the unique challenges that the communities are facing. And then also, appreciated your policy making, advocacy, and how systems can partner to build and create that lasting, sustainable impact within healthcare. So thank you for joining us today.
I appreciate you having me. We enjoy any opportunity that we can be part of the story of how all this evolves. Welcome to do it. Thank you for hosting this and creating that opportunity.
No, thank you. I appreciate your partnership. And thank you to all of our guests joining us today on Elevate Care. I hope this conversation leaves you with new perspectives and ideas around workforce strategy, leadership, and the overall future of rural healthcare. And if you found this episode valuable, please consider sharing it with a colleague and subscribing on your favorite podcast platform. And you can learn more about this episode from our show and our website at amnhealthcare.com, and follow us on social media to stay updated on new episodes as they came out and in the ever-changing world of healthcare.